All right, guys, welcome back to the world's greatest plastic surgery podcast, Plastic Surgery Untold. Back with Dr. Adam Weinfeld and our two special guests, Mark Albert. And please go ahead and introduce yourselves, guys. And
thanks for having me. I'm Mark Albert. I'm a plastic surgeon. I'm in the Upper East Side of Manhattan. I'm a private practice. And I also have a position at our hospital, Manhattan Eye, Ear, and Throat, as the program director of the fellowship.
Perfect. And Dr. Paul Afrooz.
Paul Afrooz. I'm a plastic surgeon in Miami, Florida. And I'm very excited to be here with you all once again today.
Yeah. Perfect. And so I think we're having a very special topic near and dear to Dr. Weinfeld's heart, and he's the master that's teaching me since I'm just a little bit newer out in practice. So I'm going to kick it over to him to get us started.
I always get nervous of the word master and expert as it relates to rhinoplasty, because I think even the people who have been at it for 20 or 30 years still suffer a little bit of imposter syndrome because of how amazingly complex and thus rewarding the procedure is. Mm-hmm. So thank you, though. I appreciate that. And yes, we're here to talk about rhinoplasty. I know that it is a topic that is near and dear to all of our hearts. And by, the nose is the keystone of facial appearance. It's like literally in the middle of the face. It's just literally in the middle of the face. And so it's so important. And we had a little discussion before the podcast about what we would talk about. And I think that we have a wonderful opportunity to help patients understand the benefits of closed rhinoplasty and open rhinoplasty, given that we have practitioners here who have experience with both. So with that said, I'm going to have Mark first describe closed rhinoplasty in a way that patients understand the difference between that and an open rhinoplasty.
Right. So let's preface this by saying there's different ways to skin the cat, and one is not better than the other, so that's definitely not where we're going. It's just two different ways, how you learned it and how you prefer it. So I do 100% closed rhinoplasty for all my primaries, all my revisions, etc. The main difference, the way, we can get into whether it's hybrid closed rhinoplasty or, all these different versions of it. The way I think about it is, do you make an incision on the columella, which is the underside of the nose, and do you lift the tissue up in order to access the nose? And to me, I think in open rhinoplasty you do, and closed rhinoplasty you don't. But again, advantages and disadvantages to both.
Yeah. And so I imagine a little bit of why you gravitated to closed might have been to do with your training, but I imagine also there's certain aspects of it that sort of suit the way you like to do things. You see your advantages, not, clearly you said it's not that one's better than the other, but just so patients understand how did you end up doing what you do?
I'm worried about Paul kicking me under the table here as I go into this conversation. Yeah, and again, I don't have.
He's going to have his time, so we'll talk about open.
Right. So, and I don't have a ton of open rhinoplasty experience,
Yeah.
so a lot of this might be off target. The way I see it is that, I think I appreciate when I'm doing rhinoplasty, I like having the skin envelope intact. I like being able to make changes and immediately see what those changes look like with the skin down. Where I think Paul and other people who do open rhinoplasty make changes and then bring the skin down. And when I tried doing that early on, it just didn't make sense to me as well as closes.
So, I do a lot of rhinoplasty. I love the open technique. I actually left early from a lecture that was being given by Mark Costantian because I do some closed rhinoplasty. And what you said was, essentially his sort of selling point. Right. And it's not that you're trying to sell anything, but like that is the principles that guide him and why he chooses closed rhinoplasty. We're going to get back to that a little bit, but I want to have Paul kind of describe what open rhinoplasty is and why he likes that. And I may have something to add to, since that's the way I go about most of my procedures.
Absolutely. And I think Mark nailed it. We want to get a beautiful result. And how you get there is highly variable depending on the surgeon, the training. I love open rhinoplasty. My mentors were open rhinoplasty surgeons. It allows me, I think, a degree of precision that in my hands I otherwise would not have. It allows me a degree of exposure and visibility that in my hands, based on my training, I otherwise would not have. But I do know that if I'm going to open a nose, even though that scar is a 3 to 4 millimeter scar in the column of skin that separates the nostril, I have that added responsibility of closing that nose in a manner that is of the utmost precision, because, like all of us here, we're all heavily involved in education, and we've got to show our results at meetings and to residents and fellows who are learning the procedure. And if I'm doing open rhinoplasty and I'm showing that base view and the scar is just completely unacceptable or even perceptible, that's a problem.
Yeah.
And so I can honestly say that I put forth a tremendous amount of effort in the closure of that incision. And as a result of that, I can also honestly say that in the time that I've been in practice, I have never had a patient complain about that incision.
Yeah. Yeah. So what I'm hearing from Paul is that he, in his hands, he likes an open approach, likes to see the anatomy, but he wants his patients to have an experience where they don't think of the scar. So they're not saying, oh, well, I love the results, as I look at them straight on in the mirror, but I do have the scar. Maybe, closed might have been right for me. How about this? So I will say again, I do mostly open rhinoplasty for a couple of reasons. One is educational, like that's what I was exposed to as I was learning to do rhinoplasty. I do like the anatomy, but I've actually started to do some closed rhinoplasty. But I do it for patients that it's more of an augmentation rhinoplasty, meaning that they have a low bridge and they want to have more projection to the bridge. So, without, certain ethnic types of noses where without, erasing their ethnic identity, those particular patients just want more of a bridge, and we can get into that later. But I want to understand a little bit better how to go about the procedure the type of patient, i.e. the patient who has excessive projection, a large hump, and I want to learn from you, Mark. I want to hear some understanding of how do you address the patient that's not the patient that I do the closed rhinoplasty on. So, i.e. the patient who has a bigger nose. We're not adding, because I feel comfortable adding in a closed technique. I want to hear about subtracting. Can you tell me a little bit about your approach to that?
Sure. So I actually use even a modified closed rhinoplasty incision where everything I do is just through a rim incision, or I call it a modified rim incision. And basically, there are different cartilages in the nose. There's something called the lower lateral cartilage, and I basically use an instrument to push that down, and then I use a lighted Aufricht, which is another instrument that basically lifts up the skin, and it projects light into the cavity so that I can clearly see everything that's going on. And basically, I remove tissue using either a knife or scissor, or like what we call an osteotome, which is like the tap that people hear about to remove bone. And yeah, everything is done by keeping all the skin down.
So I think, Mark and not Mark, Paul and I, both practitioners of open rhinoplasty, will probably agree that one of the more challenging things in any rhinoplasty, especially in open rhinoplasty where you can see the cartilage and the bone that have been reduced, one of the more challenging aspects is how do you make sure that's perfectly smooth? And so again, for the audience, I'm going to break this down for a second. So nose, upper half, upper third made out of bone, lower half made out of cartilage. So it's like soft stuff that's similar to bone, offers some support. So cartilage and bone together to it's that framework that creates a nose that a patient sees as too big. To make it smaller, we remove bone and cartilage, and you have to reassemble that after you remove it, and you want to reassemble it in a way that creates a very smooth bridge. So after breaking that down, what I'm saying is that it is challenging. That's one of the most important things, is make sure that's smooth. It's not that you have less visibility, but help me understand like your strategies to make sure that that's as smooth as possible, because you aren't looking at it top down. You're looking from the bottom.
Such a great thing to bring up. So it's all about palpation. It's all about feeling the nose, because it's so easy to be tricked by just looking at it. Soft tissue swells, et cetera, et cetera. You may think you have a hump or you don't have a hump. It's all about wetting your fingers, putting your fingers on the skin, running it over, feeling where adjustments need to be made.
Okay. All right, Paul, probably very similar to how you think about things when it's an open rhinoplasty. Any additional comments about how to create a really smooth dorsum?
I would just echo what Mark said. There are a lot of things that can fool you. Palpation is so important. Running a wet finger, things can look smooth, but for all you know, there is a very small chip of bone under your Aufricht retractor that you're not seeing. So there have been several times where Everything looks good, and I palpate and I feel something, and that forces me to inspect. And sure enough, something is there causing a minor issue. And so I think Mark nailed it with the palpation.
Yeah. Sean, I know you actually have some experience with liquid rhinoplasty. Can you, that wasn't really the focus, but I think it's important to talk about that, why a patient might want a liquid rhinoplasty or why you might suggest it. And then we'll ask if either of you two do those procedures.
Yeah, the majority of the patients that I have coming to me for that are really they're sort of trying to test the waters. They're not quite ready to commit to the long recovery of rhinoplasty. And honestly, they may not have the financial means to do that.
Mm-hmm.
And so I've trialed a few different injectables and gone through several different iterations, but I've settled on using something very firm for the dorsum, the nasal bridge to sort of help remove any hump, and then something a little bit softer to help just produce a little bit more tip refinement. And that's the majority of what I do. Also, sometimes inject a little firm just at the base of the nose to help add a little bit of projection.
Yeah.
And it's a great way for patients to sort of take it on a test drive. The fillers that I tend to use last about 18 months to 2 years, so they get a pretty good, durable result out of it. Yeah. And I've had happy patients so far.
And I think it's important for, potential patients listening to this to understand is that with a liquid rhinoplasty, you can't actually subtract. So you're adding something, but by adding something, you can create different contours that can make it look as if something has been subtracted, in particular, a relatively subtle dorsal hump. Mark, Paul, do you guys use fillers at all? And do you guys use them, let's say, to address little postoperative contour irregularities, or do you guys do full-on liquid rhinoplasties? Either one can go.
So I really shy away from liquid rhinoplasties. I ultimately, filler in my eyes is a gel. Okay, so if we've got a bump on the nose, a bump can be, it's a valley next to a mountain, and we can make that mountain look a little less prominent if we fill the valley usually above it. So that can diminish the appearance of a bump. I think that's okay. It's not my preferred way of dealing with it, but I think that that's okay. What I take a little bit of an issue with, and Sean, you're no different than many providers out there who do liquid rhinoplasties, but having opened as many noses as I have, I mean, filler, it's a gel to me. In the most simplistic form, it's a gel, and to expect that we're going to get tip projection or definition or any sustained changes to tip shape, that just doesn't make a lot of sense to me.
Yeah. Well, and I'd have to say there's elements of what you said that I agree with, but I do think also the idea of in the appropriate patient with appropriate expectations.
Absolutely.
Yeah,
that's right.
That there are some subtle changes that might satisfy their.
And I like how
desires.
Sean phrased it, just testing the waters to see what these changes are, because I think you opened a little bit of a conversation that we need to have. These are big changes.
They are
that we're imparting on patients' faces, and it's nice to dip their toe in the water with some filler to let them know what they can anticipate.
Yeah, and I think maybe one, and I didn't want to go too much into liquid rhinoplasties, but I think it's important to understand that in no way is it a substitute. It is a totally different procedure and process, but that in the right patient who understands what they're getting and what they're not, there is value to it. But
completely agree.
I have to agree with you in that I think that certainly the patients who are coming to see those of us who do rhinoplasty, they've kind of self-selected, and their patients are so intelligent and savvy now. They kind of, I think they're understanding where they're headed and the kind of changes they want probably they probably need to be manifest through a surgery. So but there's definitely value in that without a doubt.
So, yeah, Mark, I do have a question for you, just sort of piggybacking off what you said, Paul. So let's say someone has had liquid rhinoplasty done, but now they're coming to you because, you know what, I want the full deal. I'm ready for it. how do you treat that patient? Do you dissolve their filler before taking them to the OR, or do you say, well, just let it stay?
No, the former. I always
Yeah,
dissolve it or send them back to where they had it, and then I usually like to wait a few months just to let all the inflammation settle down, and then take them for the rhinoplasty. But I echo what all of you are saying. It's a nice option for the right patient, but it's never a substitute for the real thing.
No, we call it liquid rhinoplasty, but it's really not at all. The changes are very subtle. Really, we can help and minimize a dorsal hump, but it never goes away.
And rhinoplasty is an investment in this case.
It is.
It just makes a lot more financial sense just to do it once.
Absolutely.
So we have about 5 minutes left, and there was something I really wanted to talk about, and that is I know that we all see this in patients. The patient who says their nose is too wide, it especially is wide when they smile. Doctor, I want you to make my nose less wide when I smile, especially here. And for those of you who are listening, it's like nostril to nostril, alar base to alar base. We'll just go counterclockwise. Paul, how do you address that in a patient?
So I always discuss the limitations of the operation with the patient. I am very confident that a lot of times I can get a lot of improvement in those patients, but if a patient's really pinching in their alar bases and simulating something that's a drastic difference than what they have, I'm very quick to let them know the limitations. That can create a lot of distortion and a lot of incongruity. So it's something I carry out with a lot of caution if I'm doing an alar base reduction. But a lot of times just by creating more projection to the tip, creating more shape and contour and elegance to the tip, it's such a three-dimensional phenomenon that the nose just looks better. And because that nose looks so much better, it tends to draw their attention away from that one isolated thing that was so concerning to them. And we do get improvement there anyway, but I think the overall refinement just takes their focus away from that one nagging issue.
I want to hear what Mark and Sean have to say. You made a couple of really important points. Such a cliche, but obviously a happy patient is one in whom you were able to set expectations. So I think in some ways you're saying to some patients, you have to say, I hear what you're saying, that's resonating with me, and it's going to guide what I do, but there is a limit to the extent at which I can narrow that alar base. When you smile, your nose is still going to widen. But then you went on to say something really important as well, and that is that there are certain relationships between the sub-features of the nose and also the relationship of the nose to the face that when you alter one, it changes the perception of the other. So creating more tip definition can also make the alar base look less wide with smiling and without smiling. And then one final thing too is to help patients understand, and also we kind of understand the psychology of this, that they come to us with this basket of things that are important to them. And sometimes in reality, we can only provide them, 75% of what's in that basket. Yeah. But if you do that and you do it really well, they don't focus on those other issues as much. I love the psychology of it. Mm-hmm. And I think I'm actually very open with patients and helping them say there are certain things you think are really important to you now. You're not going to care about them afterwards. Yeah. Usually I'm right. Okay, Mark.
For me, both of you bring up amazing points. For me, it really just comes down to before surgery, is the width of your nostril already wide? If that's the case, then doing a procedure like Paul eloquently talked about, like an alar sill reduction or an alar base reduction, where you remove a little bit of tissue from the nostril in order to make it less wide. If it's not wide and it really is an issue that comes about only with smiling, then either we have to accept the fact that it may widen with smiling, or you can add a little Botox to the muscle.
I was hoping you'd bring this up. Thank you.
That acts to pull the nose out when you smile. So that to me, that's how I think of it.
How about releasing some of the muscular attachments? I recently saw Dr. Guyaran, who I think we all probably know pretty well, but some of us, well. He had discussed about releasing some of the muscle attachments. Anybody with any experience with that?
Yeah, so Dr. Guyaran's been a great mentor to both of us, and actually that's how Adam and I met many years ago. So he's a wonderful teacher, and it's something that he taught me, and I've done it. And if you smile, you're going to get some widening, regardless of what you do.
That can't be said enough. So thank you for saying that one more time. But go ahead, please.
Yeah. I mean, we can't stop patients from smiling. We want patients to smile. Hopefully after the rhinoplasty, they're smiling even more. But we can diminish the extent of pull that smile musculature has, imparting widening of the nose.
Yeah. I hope I didn't cut you off, Mark. Was there anything else? Yeah. Yeah. And Sean, any thoughts about this and how to counsel patients?
I mean, at this stage of my career, I'm right in line with what Mark says. I'm looking at my facial proportions, the facial fifths, and it's like, okay, if we're outside that, then I think doing an alar base reduction is completely reasonable. But outside of that, it's like, okay, maybe we should talk about, Botox or something like that. I think you brought up a really important concept, and this is something that is true in body contouring, but it's true everywhere. The nose is, things aren't in isolation. Someone thinks they have a wide nasal base, but if you do correct their surrounding structures, all of a sudden now it's back in proportion, it's back in balance, it's back in harmony. And so that's not a concern anymore, just like you were saying.
Yeah. And it's all about, again, these are such cliches, but like it's about telling your patients in advance what can happen, what may not, and that's so true with rhinoplasty because the patients are so detail oriented, and also you got to remind them afterwards about some of the things you talked about. Steve Bird, who I think we probably all know a little bit about, he gave a lecture to us where he said rhinoplasty is the one procedure where you have to convince a patient in advance you can do a good job, and then convince them afterwards that you did a good job. And it's just reminding patients, hey, we talked about this kind of thing, we didn't talk about this, et cetera.
I have a couple quick questions. So I think we would all agree this is one of the most challenging operations in plastic surgery. It's certainly not for the faint of heart. What do you think it is about a surgeon's personality that draws them to rhinoplasty?
That is a fantastic question. Mark, first.
For me, it's the instant gratification of seeing a patient a week after surgery, them taking the splint off, looking in the mirror, and that just feeling so happy and making a real immediate change in patients.
Some patients, they get teary.
Oh, yeah.
That's like I'm getting a little bit choked up thinking about it. It's really incredible. But I'm sorry, was there more that you wanted?
No, that's it. That's it for me.
Yeah.
I would say very much the same thing. I think part of what we deal in, and this is related to your Instagram handle, is happiness. We sell people, we provide happiness. We provide that confidence boost, that interaction with the world that changes that person's experience on an everyday basis. And so that's what I love about it, because it's such a focal point of our entire life.
Yeah. For me, it's the mix of the technical aspects of it and then the psychology as sort of the fertile ground for the happiness of the result. And I really like that. I like, kind of getting to understand patients, what makes them tick, even if I don't understand in words, just kind of reading them and making sure I'm giving them the best me I can give them and meeting their needs. Yeah, I love it.
I have nothing to add. I think you guys hit it all.
Well, guys, I know you're busy. Thanks for taking time out of your day to come hang with us. This has been a truly fascinating and educational talk. Hope all of our friends out there enjoyed it.
Why don't we give our two wonderful guests an opportunity to say where they're at in case people are in those cities and are thinking about having surgery on their nose?
I'm in New York City. Instagram and all social media is at Albert Plastic Surgery. Thank you both for having us.
Yeah. And then Paul?
My name's Paul Afrooz. I'm a plastic surgeon in Miami, Florida. My Instagram handle is at dr.paulafrooz. And this has just been such an enjoyable time. Thank you for having us, and hopefully we can do this again.
Yeah, absolutely. Yeah. Sean, thanks for being my co-host. This is wonderful. It's great to see you again. Nice to meet you. My sister lives in New York. Perhaps I'll come and visit.
Please do.
Yeah. And we'll see you guys hopefully maybe at ASAPS or ASPS, but definitely at ASAPS in 2 years.
Awesome.
Yes.
All right.
Great.
All right. Bye-bye.